I'm Michael Mandanas, and I'm a junior in the Department of Biological Engineering at MIT. Now let's talk COVID. COVID-19 has an incredibly unpredictable disease course. For most people who contract it, symptoms basically resemble those of the common cold. Coughing, fever, fatigue, with a few unique ones thrown in there like loss of taste and smell. We call these cases mild or moderate. On top of that, there are some individuals who are entirely asymptomatic, who can spread the disease but don't suffer from its effects themselves. However, some, especially older patients, can develop severe disease that requires hospitalization and oxygen, and these cases may become critical, requiring intubation in the ICU and possibly leading to death. But why? Why do different people respond so differently to the same virus? Well, recent studies have shown that it has a lot to do with how each individual's immune system responds to the infection. So let's talk about each of these different cases and try to provide some explanation as to what role the immune system plays in each one. First, I want to talk about asymptomatic individuals. Scientists estimate that the proportion of infections that won't result in symptoms can range anywhere from 17 to 50%. Because many asymptomatic individuals might not even realize they should come in for testing, this number is really difficult to nail down. These individuals likely have an extremely efficient immune response to the virus, allowing them to clear out the infection quickly and quietly. Unfortunately, to date, there have been no major studies on what that response looks like, so explaining exactly what's unique about these individuals is not possible. However, it likely has something to do with a combination of genetic influences, previous exposure to specific pathogens, and environmental factors.
However, even if they don't have any symptoms, they can still spread the disease. Some researchers even believe that asymptomatic individuals may be driving the ongoing development of outbreaks, as they're probably not even aware that they're sick in the first place. Because of their unawareness, they might be interacting with a larger number of people as well, putting them at unnecessary risk. This just emphasizes the need to follow all of the suggested guidelines to reduce disease spread. If you could be infected without knowing it, things like wearing masks, social distancing, and washing your hands often can protect you and those around you from anyone who might be asymptomatic.
Next, let's talk about mild or moderate disease. These individuals usually do not require hospitalization and only have mild symptoms like coughing, fever, loss of taste, etc.
A majority of COVID cases fall within these categories, somewhere around 80%.
In most mild cases, patients are able to recover without any external treatment. Studies on patients with mild disease have showed what kind of immune responses are usually successful. In this series, we've talked a little bit about innate and adaptive immunity, so I won't go too into depth here, but since the innate response is pretty similar no matter what disease you're talking about, let's talk about the more specific branch, the adaptive immune response. Once the body is exposed to coronavirus viral particles, or virions, the adaptive immune system can begin its response. Although the first time an individual is exposed, this can really take a couple of weeks to ramp up.
To start the process, viral particles and proteins are broken down by groups of cells called antigen-presenting cells. These viral parts are then presented on the surface of the antigen-presenting cells and displayed to a large library of T cells and B cells, each one recognizing a specific pattern. When a match can be found between an existing T cell or B cell and the specific piece of viral protein, called a viral epitope, those T and B cells become activated. They begin proliferating, and they undergo processes to increase their affinity to the viral epitopes.
This occurs in secondary lymphoid organs like the spleen or the thymus. Now, once these cells have matured and proliferated, they can begin the process of clearing out the infection.
B cells function by producing small proteins called antibodies that can bind to specific parts of foreign invaders. One of these specific parts is the spike protein on the surface of COVID-19, which the virus uses to enter cells in the first place. When B cells produce antibodies that can bind to the spike protein, this prevents viral particles from entering uninfected cells, and can also recruit other immune cells, like macrophages, to destroy the virions. T cells, on the other hand, can be split into two categories. Helper T cells activate other immune effector cells, like B cells and killer T cells, in order to make the immune response more efficient. Killer T cells are able to recognize infected cells and kill them directly by releasing granzymes, which can enter the infected cell and disrupt its internal functions, or perforins, which can poke holes in the membrane of the target, with either method leading to cell death. Studies into patients who recovered from mild or moderate COVID-19 have found that the immune response relies most heavily on these killer T cells, or cytotoxic T cells.
After the infection is cleared, the body usually retains a portion of the immune cells specific to COVID-19 as a set of memory cells. In most infections, this memory would come from the continued presence of specific circulating antibodies and memory T cells in the blood. But some recovered COVID patients actually lack these specific circulating antibodies, implying that immune memory against COVID-19 may also depend more heavily on T cells. So that's what the mild response looks like, but what changes in patients undergoing severe or critical infection?
About 20% of COVID infections will be severe, and a quarter of those will be critical.
There's a term you've probably heard brought up a lot whenever COVID is mentioned: comorbidities. The term comorbidity refers to a medical condition that affects a patient at the same time as the condition of interest, in this case, COVID-19.
Some of the ones defined by the CDC include cancer, diabetes, and obesity, although there are many more. A large majority of patients with severe COVID have at least one. Comorbidities can increase the risk of contracting COVID and may also be associated with higher disease severity. For example, patients with conditions affecting the lungs, like COPD, already have issues breathing. Developing COVID would only make that worse. In addition, older patients are significantly more likely to develop severe disease than younger patients, leading to a much higher death rate for the elderly than for adults or children.
In the hospital, these high-risk patients often develop symptoms and conditions much worse than those of mild or moderately diseased patients, like pneumonia, which is inflammation of little sacs in the lung called alveoli that exchange oxygen and carbon dioxide with the blood, or bronchitis, which is swelling of the bronchial tubes in the lung that connect those little sacs to the windpipe. Now, these conditions can make it very difficult for patients to absorb oxygen, usually necessitating supplemental oxygen or even intubation. Now, beyond that, when the immune system fails to clear the infection through its usual mechanisms, this can lead to another severe issue, called cytokine release syndrome or cytokine storm.
When the SARS-CoV-2 virus enters the cells that cover the surface of the lung, called epithelial cells, it has to first bind to a receptor called angiotensin II converting enzyme, or ACE2. After binding, the whole complex interacts with a pair of protein scissors called transmembrane serine protease 2, which cleaves the complex of the spike protein and ACE2, allowing for the virus to enter the cell. The ACE2 receptor is brought into the cell as well, meaning infected cells have fewer copies of it. ACE2 normally interacts with a molecule called angiotensin II in order to control blood pressure. However, with fewer surface copies, the level of angiotensin II in the blood increases significantly, a sign associated with lung injury. This signal puts nearby cells into a sort of panic mode, causing them to release lots of little molecules called cytokines that cause inflammation and are meant to aid the immune response. One of the most important of these cytokines is called IL-6, which can cause cells to make even more cytokines.
On top of that, in patients with severe disease, T cells are forced to be active for long periods of time, leading to hyperactivation. When T cells are too strongly activated, they may begin to release large amounts of cytokines in order to compensate for the initial unsuccessful immune response. These and other factors can contribute to a condition called cytokine storm, or cytokine release syndrome, where the body becomes absolutely overwhelmed by these inflammatory molecules. This is really dangerous, because systemic inflammation can damage organs throughout the entire body, potentially causing entire organ systems to fail. In the lung specifically, this can lead to a condition called acute respiratory distress syndrome, or ARDS, where fluid builds up in the lungs and it becomes very difficult to take in oxygen. Even when put on a ventilator, the presence of fluid in the lung can block that oxygen from getting to the rest of the body. As high as 70% of all COVID-related deaths are caused by ARDS, perhaps associated with the cytokine storm. However, cytokine release syndrome isn't something new to scientists. It can happen anytime T cells are too strongly activated. As an example, some cancer treatments work by increasing the activity and function of T cells, which in and of itself can lead to a cytokine storm. To solve this, scientists have developed drugs that block the production of cytokines, like tocilizumab, which inhibits the function of IL-6. This drug and others like it have been effective in preventing the cytokine release syndrome in other situations, so scientists have begun testing them on severe COVID infections. While there's no conclusive evidence as to whether or not the drug works in this circumstance, targeting the cytokine storm may help save countless lives in the future. I hope this video has helped shed some light on the different ways a COVID infection can end up. With that, thanks for watching, I hope you enjoyed, and until next time, this is Michael Mandanas.